Hello, and welcome to Chapter 26, Week 1 of Pediatric 334 Theory class at National University. I am Professor Ann Holler, and I will be speaking to you about the growth and development of toddlers. Chapter 26 in your Walters Kluwer slides. We want to talk about the various elements of growth and development with toddlers, just as we did previously with the neonates and the early infants. So we'll talk about the measurements that we take for physical growth. The weight of the child will increase quite steadily, but in spurts. So they'll go maybe a week or two, and then there's a period of growth where they seem different. Usually they will be eating more as that's happening. That might be an indicator that you see the change. And they are growing at a slower rate than infants do, with an average weight gain of 3 to 5 pounds per year. The length and height increases steadily also in spurts, but at a slower rate again than the infant, with an increase of about 3 inches per year. So they will attain their adult height by half by age 2. So it gives you a good indicator. A lot of people want to compare different family members, or are we after this side of the family or that? And it's a rough estimate. It's not hard and fast, but it just gives an estimate that the height of a child at age 2 is about half their adult height. So head size is much more proportional to the body and increases so that by age 3, the proportions are much more appropriate. So what's important for us to remember the things that we're looking at, we measure head circumference, and that's important. It's related to the neurologic system, and the fontanelles that close. So remember, anterior, posterior fontanelle, the bony plates of the head. Those fissures will close much later, but it's much more important that we're observant of the fontanelles. Anterior fontanelle will close by 18 months. So it's important to know when those fontanelles change, because once they close, then we don't continue to measure head circumference. Their brain is growing rapidly and retains about 90% of its adult size by age 2. The myelinization of the nerve fibers are continuing, so that we see improved coordination, balance, and most importantly in toddlers, sphincter control. So this is the age of potty training, and we'll be talking about that a little bit later. The respiratory system, the alveoli, continue to increase in number, and the trachea, remember, is small in the infant and continues to keep that small size as compared to an adult. So choking hazards remain an underlying issue. Tonsils and adenoids are relatively large, and this is the time when sometimes we see repeated tonsillitis and occasionally removal, although most, the current philosophy is not to remove the tonsils, but just allow them to remain. The cardiovascular system shows us that the heart is going to have a decrease in its rate. So remember the newborn, it's always easy to think about OB and what those rates were on the fetal monitors. And so that we watch that gradually decline as the heart takes on more efficiency. Blood pressure will also increase. And so we'll see those changes occurring. Now, in the gastrointestinal system, the stomach size does increase. So the child is eating less often, more in the normal span of family mealtime with snacks added. The small intestine will continue to grow in length, and they will produce less stools, usually size and shape related to diet. Bowel control is typically achieved by the end of the toddler period, so by about 3. Some children will do it sooner, others will do it later, but that range is in the toddler period. The GU system, the bladder and kidney, have reached adult function between 16 and 24 months. And that's why when we talk about the potty training, bladder control is able to be achieved because not only the sphincters, but the size of the bladder allows for more adult-like function. That capacity does increase. The urethra remains short relatively, and so the risk for infections, particularly in females, is still present. So being alert to that. And it's tough because this is a time when kids' hands are everywhere and they're not always very clean, and they're reaching in their diapers and they're touching themselves. And so we need to be alert to hygiene issues related to the urethra. So the muscular system, musculoskeletal, they're maturing, and the muscles are becoming more capable and coordinated. And so we see the movement of the child through toddlerhood going from that wobbly stance of the 1-year-old into the 2-year-old, where they become able to not only confidently walk and be upright, but they're actually running. And so we see that progression occur and see it move in stages. So a bit of awkwardness, then more stability, and then confidence in movement. The sway back and pot belly of little children, of toddlers, is typical, as we see in this little girl on the right. If we saw her on the side, we would be able to kind of see that curvature in the back, in the lower back. And that's pretty typical. By about 3, we start to see that slim down. And so they take on a different posture in that preschool period. So this is pretty typical of what we would expect to see. And she's very happy to show off her belly. And you can see she is still wearing a diaper. All right, so that's what's happening with this little girl. Sensory development is important. Hearing has been intact since birth, and that's why we're always alert. We talked about that in the previous lecture, of being alert to delays or less expectation than what's happening, so that the child does respond to sound. So we're very observant of that, and we do it right from infancy. So when we're looking at them, startle reflex, things like that, when the child doesn't respond to that loud sound, we should be alert to that and look at the ability of, first, we always look at the function of the body part we're concerned about. Does it work? Then the next level we look at is, do they understand? Is there cognitive connection to understand that the sound has occurred? So those are different things to think about, but we're always going to look at the physiologic function first. So like when a child is, scrunching their eyes up and looking, the first thing we're going to do is check their eyes. We're going to give them a vision test before we get into all kinds of involved, do they have learning disabilities, blah, blah, blah. It's much more important to say, does the body work the way we expect it to? And if it doesn't, then we're going to make corrective measures and then reassess as to what the cognitive connections might or might not be. So visual acuity does begin to improve. So remember, little children have much more gross vision, and we're not seeing 20/30, 20/20 to occur in this age frame. They're more likely to be 20/30, 20/40, maybe 20/50. We still consider that to be normal. They are not being required to have visual expectations as far as like reading font or seeing things that are smaller, discrete. It's a general vision acuity that we're looking at, and it gets better with time, with just the maturity physically of the eye. So they are very distinct at describing spells, or liking this or not liking that. Sometimes it's food, sometimes it's textures. Most people like cuddly, soft things, but there are other people who might like scratchy, and they're exposed to different things. Parents will notice if there's an undue sensitivity, and will usually move away from those sensitive things and be alert to it. It's just like now we see very few labels in clothing. It's because we realize so many people were sensitive to that label on the back of their neck or the back of their mid back. And so manufacturers started to respond by just printing the information onto the fabric. So things have changed rapidly in really a very few short years to see how the marketplace responds to people's desire. Their overall environment around them and how they explore it is very important at this time. They need to take on the understanding of things. So it starts very basically with noticing color, smell, touch, sound, and we allow them to do that in lots of ways. And it's important, especially for first-time parents, to give them permission to let them be messy. You want them messy now. It's socially acceptable to see a toddler like we see in this picture, all covered in whatever that is. I don't know whether it's peas or finger paint, but again, they got the texture and the tactile sense of it, and they're able to play and explore with freedom. And so have them create an environment where the child can do just that. And it's sometimes put down a shower curtain under the high chair and let them have at it. The same thing with eating is they need to be messy. They need to manipulate their food. So they're going to learn to use the tools of eating, but they're using their hands as well. And that's acceptable now. It's not acceptable for a 4-year-old to be eating with their hands or a 7-year-old to be messy like we see here. So those are the kinds of things that are age appropriate. So we want the parents to allow them to experience things to help take on the gestalt of what is this, how does it feel, what is it, that sort of thing. I mean, we do certain things as we get older where we do certain messy things. I mean, paintball, wow, isn't that fun? And where did that come from? Maybe some frustrated people who never really got to experience things the way they wanted to. But exploring with all the senses is very, very important to take on at this age. Our developmental theorists are all about, the attitude of how they see it. Erickson talks about autonomy versus shame and doubt. So they achieve autonomy and self-control, and they begin to separate themselves from their caregiver. They are not that significant other. They are their own self. Piaget describes it as sensory, motor, and pre-operational. So they differentiate themselves from objects, so living or not, and increased object permanence. So they begin to understand when people or pets or whatever are not quite with them, but they know that they haven't disappeared. So in that early infant time, we talked about how they play hide and seek. So cover your eyes. And to them, literally, if they can't see you, you don't exist. So that's why they're so surprised when you take your hands away and it's a peekaboo, and they're all laughing and like, yeah, wait, you're there. So they begin taking on object permanence so that then you can cover it up, but they begin to realize that that person or pet or thing continues to exist. Example would be when a parent walks into the other room, the child is playing and they go into a different room where the child can't see them. And the child calls out, mama. And the parent responds verbally without coming to the room. So the child doesn't visually see them, but they, again, understand that the parent is still existing and they're just in a different place. So symbolic thought begins at this time. So that beginning of understanding. Freud talks again, oral anal is Freud. So the anal stage, which relates to sphincter control, one of the objectives of the toddler period. So you see this in your book, and there's much more descriptors as well. So keep in mind how the developmentalists think of it. Those are things that are asked in questions on tests all the time. So be able to relate to what is the phase and what does that mean? How does it display itself? So when we talk about emotional and social development, we're talking about separation. So we talked about that a little bit. And again, as object permanence increases, that helps. They see themselves separate from their parent. It's important, like when we're in the hospital, we see separation anxiety. The child is in a strange environment, and then significant others are not always present physically with them. And it makes for a great degree of anxiety. We want to do things to anticipate that and to help the child to go ahead and be able to understand that the parent is still present, the parent will return, and to reduce that anxiety. Individuation happens, they start to see themselves as that separate person, and they'll start to use words and phrases, me, mine, and so they're very much about the me. Learning to control their environment. You'll see that with play, certain things that they'll do with their toys, or to put themselves in a certain place or be with a certain person. And we start to see emotional lability. So remember that we talked about sleep and sleep deprivation previously. Remember that that's part of an underlying thing as to emotional control when they're learning to manage their own behavior. So if they're sleep deprived, that can foment that mobility. So we want to always think, has the child been well rested? Where is the environment? What do we do to change that environment to help the child be more calm or be able to manage what's going on around them? Sometimes it's the tactile thing, being able to hold them or snuggle them, or even just be able to verbalize to them, it's okay. And some of the things that parents do to help them understand, like when they're hurt or something, certain things you have to be really worried about and others you're not. So it's a little scratch, is it, oh, it's a boo-boo, and and you treat it minimally. You don't make it like third world, like their fingers falling off. And new parents sometimes have a hard time with that because they're over solicitous, and then that can actually make the child more anxious. So it's important to kind of keep some moderation there. They are focusing on themselves. They are egocentric. And so it's important because they have to understand me to understand you. So it moves forward with time. So this is the beginning of seeing those changes occur. Typical behaviors that we see. Again, they like those security items. Linus is one we always remember. He carried it on a little longer, but it was important to him. So gender difference awareness, they are playing out roles, beginning to understand, what things mean, what does it do, and they will assign certain categories. Whether or not those are real or not is not important. It's how they are experiencing it and they see it. So it could be about cooking. It could be about, parent behavior. Sometimes you hear them repeat behaviors that something the parent has said, maybe even to another child, is don't do that. And so they're taking on some of that posture and beginning to be aware of, moms and dads, him and her. And again, it's very fluid, and it should be. They are not abstract thinkers. This is all very concrete. It's what they see. So they're responding to what they see. And so it's important to allow them to explore that and not worry about, what this means or that. It really just is a period of exploration in their behavior. Unclear boundaries, okay? They become more self-aware, but they don't know how to contain themselves or to stop themselves, or they get overly excited. And sometimes we have to calm them down because their behavior is not inappropriate for the or appropriate for the circumstance they're in. They like to be all about themselves, but we look at things where, we're helping them to conform to some of society's norms. So you take them different places. Where do we not take, toddlers? We don't take them, generally you don't take them to the theater, all right? Even if it's a matinee, they're not going to do well. And because they have limited attention span, limited ability to integrate into what's going on around them. So they have unclear boundaries. We need to respect those and not put them in areas that stress them more. The invasive procedures, okay, that very much comes into our realm, because we're going to see them in clinic or wherever in the hospital, and we have to do things to them that they might not like. So we have to find ways to ingratiate ourselves, to build a trust with them, and then to gradually do it. And so remember, how we do assessment with children is different than we do with adults. Adults, we do the head to toe, right? You just do a physical, you've done that. So you understand what the process is. With children, we have to take a different approach. So the first thing we do is observation. We're not touching, and even in the beginning, especially a first time, or second time opportunity, the child doesn't know you. You don't have a trust with them. You're a stranger. And they're afraid of strangers at this age because they have differentiated their circle from the outer circle of, society at large. We're part of that until we help to make a connection with them. So we're going to have to build some trust. So how do we do that? Well, we start with coming into the room, generally, visually spanning the room and not focusing directly on the child, like making direct eye contact is not always a good idea right up front. It might take a minute or two to do that. So we do that by having conversation with the caregiver. When the child watches the reaction of the caregiver to us and see that there's a willingness to participate, then we can then make a comment to the baby, or the infant or toddler, and say, aren't you cute? Or what a smile. Hi, and make eye contact. So you start slowly with observational things, and then you progress. So you use the method of least restrictive to most, or invasive, so that things that we're going to do where we poke and prod are going to be at the end of our evaluation. These are things that will be asked of you in the future. So expect that. Is that how do we deal with them? We're going to get there, but we do it a different way in pediatrics. So, taking temperature and, looking in their ears and their throat are things that come at the end of the assessment, not at the beginning. And so we can do a lot of things verbally to direct them to get their cooperation. Once they realize it's not going to hurt, they're not being poked and prodded, then they'll cooperate with us. And then we can talk, and we can use play things to help them try something out so that they have less fear of it. So sometimes we have things on our stethoscope, like a little bear or whatever. And so we talk to the bear, and then maybe we let them use our stethoscope, or we have a toy one that lets them listen to the toy or, themselves, and then say, now my turn. So, and they're used to taking turns when they play. So that kind of thing, building up the trust so that then you can get the information that you need. And so you have to work it. We are very aware of that anxiety that occurs, and helping to support them to acknowledge the anxiety, but then to let them let go of the anxiety. So really important to focus on those behaviors. Motor skills are going crazy, okay? Gross motor, they're going from that wobbly early toddler gait, early walker, to walking with confidence, really using the center or core of their body, walking upright, more smoothly, moving their arms, and then moving on to being able to run and jump. And they start climbing very early on. They start using toys sometimes where they propel with their feet or with pedals, like a tricycle, running, throwing, jumping, tossing a ball, and that cooperative play that starts happening where we push and pull a toy. Those are the kind of little things that they can drag behind them, or they're pushing like a little stroller or a lawnmower. So those are all the gross motor skills we expect in the toddler period and the kinds of toys that go along with that movement. So it's important that we are child-proofing. Look at this guy in the left, bottom left, having fun climbing up on the bookshelf. So probably not a great idea. Doesn't mean he isn't going to do it. So you have to find ways to change that. Sometimes it's just putting something that blocks their ability to climb up. Sometimes it's excluding certain rooms in the house where there are too many things that can cause problems. You know, an office where there are lots of wires and things where they can become tangled, and that could be unsafe. So fine motor, we're talked about how they're able to hold and pinch and grasp, and how that matures over time, how they manage utensils. So even before they need them, we start putting utensils and objects into their hands for them to learn how to manipulate with their hands and fingers, so how that works. So child isn't eating at 3 months, 4 months, but we can start putting little spoons in their hands. And we want to give them that chance for manipulation and getting used to that. How to hold crayon. We want to, they'll start with fisting, okay, and they'll hold it in their fist and they'll make marks. But very soon, once they start really getting into it, we want to change that posture and take an object and put it in their hand to show them how they should be doing it as they mature. So rather than letting them persist in the fisting, once they've got the sense that I can move this and make a mark on the paper or the wall or wherever, then we want them to learn how to use those objects appropriately. So changing that and putting those objects. That's why we start out with the sippy cups. We have them hold and bang. They're using it like a toy. They're banging it. Put an ice cube in, it'll rattle. So, you know, they'll get a little bit of liquid if they try, but they're not going to get very much out of it. But it's important more that they learn to manipulate and they learn to put their mouth to the opening and they realize there's something on the other side. So they'll begin to suck on it or sip on it. And that's just what we want them to do, is learn how to manipulate things and become more dexterous. Working puzzles, you can see the child here on the right is matching shapes and putting that puzzle together. And interesting how the child's using their foot to kind of hold the box in place to be stable while they're moving the little objects. Using touch screens, really, really important to realize the difference between manipulatives, things that will provide function and things that we do like writing, and the screens. There are different brain pathways that are used with electronics than there are with other manipulatives. It's important that we establish and use all of those brain pathways, but we don't want to overlook one over the other. We also know that screen time needs to be limited. So we want to reduce it to the period where it has an appropriate function and that we're really sort of clocking that amount of time. A child could use a little play game on a tablet that helps them to match shapes and do it. But the toy that this child's sitting with is a much better object because they can see the dimension, right? It's not flat like the screen on a touch screen. They actually get a sense of it. So you're enhancing their ability to understand what an object is and can do. So it's really important that they use toys and that they are playing. That is the work of childhood, is play. So it's important that we use those toys and let them get the full experience. Speech development is another thing to think about, and receptive language. It's really difficult when we think about it, you know, how we take on language. So receptive language, we're all alert and aware if you had any second language in school, how much you could understand the language before you could speak it or write it. Okay, so that's and it's very evident when you're talking to toddlers. You can have a quite complicated conversation, and you can see that the toddler understands what you're talking about, but they're not able always to express it, or they're using short phrases. That's pretty typical of what we see, that they'll do that. And they use sort of telegraphic speech where they'll just communicate to you what they want to talk about, but they're using it usually between 18 and 24 months. They'll say, I hungry, this shoe wet, something like that. So helping them to express their thoughts, and then they'll start with phrases and also very I-centered, and then over time be able to take on a broader sense of language. So that telegraphic speech is things that we see very much. The echolalia is important to understand that there are different ways that echolalia occurs. It means really to repeat a word or a sound. All right, so echo may make sense. So it's part of developing speech. By age 3, most kids can choose words by using their own unique voices and intonations. By 4 and 5, they're able to ask and answer questions, carrying on conversations, and otherwise use language in their own way to communicate to other people. Also seen in disorders like autism or neurologic deficits, that autistic people may use repetitive speech, echolalia, for different reasons, and it can change over time and for multiple purposes. These words are really not their own, so they haven't generated that. They're replicating what's been said to them. So it's said in the same order and the tone that they heard it from. So if a teacher says, say thank you, they'll repeat, say thank you to the individual. And so they're using other people's words, but they're beginning to mimic what's expected of them. So it's sometimes used, echolalia, in those disorders as a form of calming strategy, where it's self-stimulating, and they'll use that especially if they're feeling overwhelmed. Sometimes it's used as prefabrication. So it's used when it's difficult or stressful to use their original words. And so they'll go back to things that they've been taught by a parent or a teacher that says, you know, when you get excited, do this, that. So the self-talk, they will memorize phrases to help them get through different processes. And they may, this can be a first step toward more typical forms of spoken communication. So like I mentioned before, say thank you. And so the child will repeat that. It calms them, and it also gives them an action that mimics what others are doing, what is appropriate in that situation. Say thank you. But they have to repeat it out loud, and that actually is calming to them because they're following a directive. When we look at bilingual mixing of language learning, we're talking about children who are in environments where they're exposed to multiple languages. There's a great benefit to that, but there also is a caveat. Children who live in a home with multi-languages or exposed in different ways through their families or socially or even at school will take on language at a different rate. So they will have a better understanding and are more able to take on new words and interested in new words in their lexicon. But some of the mechanics of language and language expression can be slowed, like meeting certain goals for reading or writing could be slower. Like we're talking kindergarten, first grade, when those things happen. So it's important for parents to advocate for their child if they're coming from a mixed language environment, because the school sometimes follows very strict parameters of they need to do this by this age and that and whatever, then write sentence with this many words or whatever. And the child may appear delayed. The child really isn't cognitively delayed at all. It's that they have such a broad view of language that they have to process more to make their decisions to what words they're going to use and how they're going to use them. Once that's attained, they usually exceed the average individual who's only been exposed to a single language. So very important to help advocate with parents who might be frustrated with a school or something saying, no, your child's delayed, we might need to have them repeat kindergarten or whatever. It's very, very important to look at that and to recognize that value. And this is one of those places where we as nurses look at the whole child and we want others to do the same. And this would be a situation where that makes a lot of sense. We talk about the actual child and their environment. They live in a home with multilingual parents and their nanny speaks a third language. And the child interacts quite appropriately with all of them. But when he goes to school, he has trouble writing sentences. So we need to not take a certain parameter and take it out of context. And that's where bilingual mixing language learning is very important to understand. Promoting growth and development through play. Again, play is the work of childhood. That's how they learn about their environments. That's how they learn to socialize. And that interaction through play will change and evolve over time, but we start to see it take importance in the toddler period when they become not so egocentric. Okay, they are, but they're around others. So their social environment changes. They're around other children, around other people. Typical because they are egocentric, they don't like to share. They will play in parallel. And it's important because these are things they ask on tests, is that what kind of play occurs at this age, and then what kind of toys do they use. So they can be playing in a room like a playroom, in daycare, or somewhere like that where multiple children are, and they're all at the same table and they may be playing the same kinds of toys, but they're playing individually. There may be a little side comment now and then, or can I have that? But very much it is not a cooperative play, it is parallel. They're side by side, but they're not interacting in the play. They're not having a back and forth. They're not developing things. As you see them get older and come out of the toddler period, they're going to do things like they put together plays, and we're going to do this. So the cousins come over and immediately they're off in another room and they're going to do those things. But the toddler is not doing that. The toddler might be directed to do some things as part of what's going on with the older children, but they are not really fully active participants. So parallel play for toddlerhood. Their attention span is short, and that's why we have lots of toys and we change activities frequently to keep them engaged. And it's important that they have structured and unstructured play. So remember that when you're looking at that, about a half an hour of structured physical activity, but 1 to 3 hours of unstructured physical play. So there may be certain things you'll do on the playground where you want them to do this or that, but then you sort of let them go and let them decide what equipment to climb on or what to dig, in the sand, those kinds of things. Very important, as we talked about screen time includes television. It's not interactive. It's not developing many things that they still need to work on. So it's wasted time in many ways, not exposing them to kinds of things that really take on full learning. So we want to encourage that creative and physical play, and that's where the bulk of their time should be happening. So having them in a different room, you might have the TV on, but they need to be maybe out of sight of the TV, or you have something on that they're not going to be interested in, so that they engage with their toys. So they're in the corner playing with toys while the adults are watching, something on television. And we want to have those toys that really engage them and let them interact. And that's why we look at things like Legos, where it could be anything you want. You can put things together, take things apart. And that's why those toys persist irregardless of time. How long have they been around? They keep evolving. But they have that element of creativity that's really important to expose children to and promote. So we have a little question here, true or false. A simple, colorful board game that requires multiple players to cooperate with each other for a common goal would be the best type of toy for toddlers. And I think from our discussion, you realize that that's false. Toddlers engage in the parallel play. They're solitary, not likely to cooperate in a game. They're not going to want to follow rules. They don't want to wait their turn, those kinds of things. So it doesn't suit their egotistical nature. The best toys, again, are little things where they can mimic and learn about role. What parents do, what engineers do, what builders do, what nurses do. They have those items that they can play with, blocks and cars. And you see kids when they're coming and going, they've always got something with them when they travel. Even you're going to the store, they've got a car in their hand, or some kind of manipulative, or a doll, something like that. So the things that work and make noise and move are all those kinds of things that help. But even simple things like chalk, sidewalk chalk, letting them go out and draw and make a mess somewhere where it's easy to clean up. How they play in the tub, those kind of things are important. And so you want to have things that are always available to keep them occupied and interested in whatever environment they're in. So gross motor toys, things like gyms and tricycles, pull toys, wagons. They like riding in a wagon, like pulling the wagon, giving them the opportunity to take control when they can. So we look at dental care. By 30 months, 2.5, they have the full set of teeth. It's important that we establish good dental care early on. And so when does that start? When the first tooth erupts. So as soon as they have a tooth erupting, then we're doing dental care. By the age of 1, they should see their dentist. Most dentists like to see them once they have a couple of teeth erupting. So you don't have to wait till 1 to do that, but definitely by the age of 1. So somebody asks you on a test, it's by the age of 1, make sure that they've done that. So the kind of dental behaviors that we take on. So in the very beginning, when they just start teething, so the teeth are getting ready to erupt, so the gums are sore and irritated, we're going to do little things to help. And I mentioned that, like the bagel, that kind of thing that you can do to just give them something to gum on helps. And once we have a tooth erupting, then we talk about dental care. You're going to just do a real simple swipe with toothpaste, many times just like on a washcloth across the gums. And we are interested in making sure that fluoride has a piece of that. Most of the child toothpaste have fluoride in them. So it's easy, just get the toothpaste because it's at the appropriate amount. It's going to be a different concentration of fluoride than it is in adult toothpaste. And remember why we do that. Fluoride strengthens our teeth. So these are teeth we hope to have throughout our lifetime. And even though those are the primary teeth, which will be replaced by the adult teeth, we want them to stay in place and be healthy until they're overtaken by the next set of teeth. So it's important that we do have strong teeth free of decay. So many times just once or twice a day, swiping a little of the fluoride toothpaste across the gum as the tooth is emerging. And then when you make the dental visit, then the dentist will talk about supplements. And usually at they'll start fluoride supplements at 6 months of age, because that's the time when the teeth are beginning to erupt. So just, why do we have teeth? We need teeth so we can eat. And so that all ties together, remembering that this is a significant time, and it ties to the fact that nutrition for the infant was just breast or bottle. And so from 4 to 6 months is when we make that transition to adding food to the diet. So that goes along with the eruption of the teeth. So they all kind of wrap together. It's important to know whether you have a local source of fluoride in the water. And even in a city like San Diego, you have to call the water department and say, this is my zip code, is there fluoride? All right, and the accepted amount is considered to be 0.3 parts per million in drinking water. That's considered sufficient to provide protection to strengthen the teeth. So always have to check, is it local? If people are using lots of bottled water, then they're not getting fluoride. Then you want to be sure that you're using that fluoride toothpaste so that they're getting exposed to fluoride onto the teeth. And the pediatrician, if there's no water source of fluoride, will give supplements, and usually to the age of 16. So it's important to remember about fluoride, how it's used and why it's used. Now we talk about sleep requirements. Well, we're looking at them getting better and better about sleeping through the night. And moving from infancy, where we had a couple of naps a day, you usually back off to 1 nap a day. And on 18 month, we expect to have about 13.5 hours of sleep per day. So that's combined nap and bedtime. And a 24-month-old at 13 hours, and then a 3-year-old at 12 hours of sleep per day. Consistent bedtime rituals are very, very important and help prepare the child for sleep. So I talked about that in the first lecture, how to create a calming sleep environment to help the child go to sleep without having to hold them until they're asleep, being able to put them down with the expectation that they are going to sleep. Set the routine that they do, read a book, say their prayers, brush their teeth, all those kinds of things. This is bedtime routine. And you start it off, it starts maybe with the bath, whatever, but building that. Discontinuing napping, usually you can tell when the child is ready to stop napping, where they're more wakeful, or they sleep for half an hour and they're done. And that's acceptable after 3 or so to see that happen. But remember the overall period of time you want for sleep in a 24-hour period. So if they're not napping during the day, then that kind of time for napping is going to be added to the nighttime hours. So keep that kind of in mind. And then promoting safety. Everything we do always has the underlying element of, is it safe? How do we keep things safe? So that increased mobility obviously requires increased vigilance. The way that we keep our homes safe, the things that we keep out of their way, we want to provide that child-proof environment, but realizing anywhere we are, we have to think about what the environment is. You could be at a stranger's house or a neighbor's or wherever, and you have to be alert. They have older kids, they don't have infants, so there are things out and about that might be objects that could be a problem. So being aware of that wherever your circumstances are, not just in your own home or grandparents' home, things like that. The safe car seats, we start with them in the back. So you need to know the state rules about car seats. What kind of car seat, what age, what weight is the child, whether it's in the front or the back. What do you do with alternate vehicles where it's a 2-seater sports car or a truck, something like that? How do we keep the baby safe? Because we might have to transport them in a different kind of vehicle. So that safe home environment, other things like exposure to things, smoke, marijuana, whatever. Water safety. Really, really important, not only in the tub, never being left alone, as we've mentioned before, but we want to think about how they are coming upon water. It could be a puddle. It could be a bucket of water with a mop, something like that. So really being alert to things that they can get into that cause problems. You see that infant or the toddler in the blue outfit who has that drawer pulled out, very typical. All right, put things in the lower cabinets where they're not breakable. They can go in and play with them in the kitchen, measuring cups, stuff like that, spoons, ladles, whatever. They can bang around, make noise, do things. But that also presents the opportunity for this little guy to climb into that, letting him be up higher and then reaching things that might be inappropriate. And that's not a stove top, but it's a countertop that could have all kinds of things. And it could be a matter of things that are sharp that he shouldn't touch, or things that he pulls down on himself and causes injury to himself. So, and we see the child at the stove, and it's really hard, the stove, teaching that hot, don't touch kind of thing. Starts as a game, but helping them to understand that is not acceptable. Making sure you turn handles in on the stove so they can't reach like this other guy at the bottom right is able to do. And that's a cast iron kind of pan. Looks like even just bringing that empty, not hot, not filled with anything container on themselves could hurt them. So we want to look at that. We want to be sure that any kind of cleaning supplies or toxic substances are well above our heads. We should put them in our upper cabinets or out in the garage, somewhere where they're not easily observed and opportunistic things that where they could reach and get them. So when we're using those kind of substances, best to do it when they're taking a nap or they're not around. And again, looking at environmental situations is that there are many opportunities for cleaning supplies that are not so toxic. They don't all have to be like super duper chemicals, but even simple things like vinegar, disinfect, do a good job. You can wash your floor with vinegar and water if it's a tile floor. And the child might try to ingest it, not likely going to go very far, but vinegar is not toxic. Vinegar is something that we use and ingest. So it's sometimes changing the methods of cleaning that can reduce all that possibility for injury and preventing poisoning. Key fruits and vegetables, okay? And it's important to remember what those are, what sources of fiber. You're going to be making recommendations. You're going to be talking about diet with them. So these are things that you should know if you don't already. The nutrients and why we use certain vegetables because of the nutrients. So dietary fiber. Fiber is important, for balance of the intestines and, consistency. So applesauce, very common everyday sort of things that kids have it all the time. Carrots, corn, green beans, mangoes, pears. There are lots of sources of fiber. Folate is important. And we see avocados, broccoli, green peas, oranges, spinach, and dark green berries, and strawberries as a good source of folate. Vitamin A, they tend to be those orange yellow things and dark greens. So apricots, cantaloupe, carrots, mangoes, spinach, dark greens, and sweet potatoes. We always remember the sweet potatoes, right? Vitamin A. And vitamin C, broccoli, cantaloupe, green peas, oranges, potatoes, strawberries, and tomatoes. So very important to know these key nutrients that fruits and vegetables can provide. Know this list because somewhere along the line you'll probably be asked about it. So we want to promote self-feeding. So as I talked about, getting them used to manipulating with knives and forks, spoons that are the size for kids. Really easy to do that. That's one of the things you want to have that's proportional. It helps that, and then cutting foods into the right sizes, little tiny portions, that they can fit in their mouths and they can manipulate and chew and swallow. So it's important that the child is part of the family process of eating. And I know many families don't eat together every meal, but having at least one time a day where they come together, and that this toddler is not sitting in a high chair in the corner, because you put the shower curtain down to keep the mess to a minimum, is pull them up and bring them right up to the table. So they're part of the conversation, part of what's going on at the table. People are making eye contact with them. Socializing and then modeling the behavior of eating are things that we want to encourage. So we want them included. And when they're doing well, you want to tell them that. Don't leave them unattended when they're eating. So just like you're not doing that with the tub in the water, because they could certainly accidentally choke, and you want to have a quick response to that. You see the ads on TV all the time. I think that interesting little plunger thing that they've come up with is kind of amazing, but I'm not sure, like, where do you keep it? Like, how would you always remember where it is? I don't know. So minimize distractions during mealtime. So, there shouldn't be screen time, shouldn't be TV. People shouldn't be looking down in their phones or whatever. It's time just for a brief time every day where people come together, make eye contact, have interaction, and enjoy their food together. So how do we do that? There's, their appetites will, come and go. So we kind of see toddlers as grazers. They'll eat a little bit and then they're disinterested. And so it's important that don't overload the plate and be unrealistic. I think the kid on the right corner probably has an awful lot of, looks like broccoli. I don't know if there's anything else on that plate. I wouldn't think that's very appealing. There maybe needs to be a little bit different color, and maybe not so much volume. It's always easier to add more to the plate, and then so sort of minimize and put what the minimum expectation is on the plate, and then add as they go along. So helping to encourage them by using different textures, different colors will help. Many kids are picky. Find out what they like, and then put something that they like on the plate along with things that maybe you're just introducing that are new, that they can try. They also will go on food jags where they always want applesauce with their lunch, whatever. Within reason, that's not a big deal, as long as they're getting the other nutrients that they need and are not reliant on just that one food source. Physiologic anorexia is what we talk about, and it's really not a true anorexia. It's just the fact that they will eat a little bit and then go away, and then they'll come back and eat a little bit later. And we usually recommend to parents that when you're clearing the table, don't scrape their plate. Just put it on the counter, do the dishes, because many times by the time you're ready to turn on the dishwasher, here comes the toddler. I'm hungry. I want to eat. Instead of throwing things away, let them do that. And it's funny when you're not used to having little children around, how small those portions are that are very appropriate for this age. So parents do well to have a lot of little containers. They can do those because they're not so wasteful. Just have little containers that they can put things in, put it in the fridge and bring it out later. And reintroduce it, and it's like, oh, look, let's have this for a snack, and it becomes more appealing. So it helps with those picky eaters or that sort of anorexia that we see. So not true anorexia. All right, it's not really about body image. It's not dysmorphia. It is just that they are growing in spurts. So when they're really physically growing, they're eating more. And then when they're not, they're less interested. So you want to look at their skin and their nails and their hair. All right. Do they have shiny eyes? Do they appear healthy? Then you're probably adequately nourishing them. So it's important that the parent doesn't get so upset that they're just not eating enough. They're really worried. Again, making it available and easy to do. And doing fun things that make food fun to eat. So most little children will, do almost anything to have a dipper, because it's that manipulative sort of interaction of their egocentric, and they can do it themselves. Is they, hummus and carrot sticks or something like that. So they take on that posture because you've made it interesting, right? So make it appealing when you can. So a nurse is planning a diet for a toddler that is rich in vitamin A, and which of the following foods might the nurse include? So it's important to remember, back to that list that I mentioned, know that list, because they will ask questions like this. Expect it. So carrots, okay, remember we always think vitamin A, we always think those orange, yellow sort of vegetables. So it's really easy to think about that. Carrots are rich in vitamin A. Avocados are rich in folate. So they give you different choices and why one fits over the other, the process of elimination. Corn is rich in fiber. And we know that because if we feed them corn, we're going to see it in their stool. Okay, it isn't completely digested. Strawberries are rich in vitamin C. People forget that, but they are a good source of C. Other foods that are A, apricots, cantaloupe, spinach, mangoes, dark greens, and sweet potatoes. So most of these vegetables, as you look at them, are orange or yellow. So it makes sense, apricots and cantaloupe. So be aware of that, some of the basic nutrients, because it will be easier to help parents make dietary choices. Doing things to encourage the child to eat those. So you take a cantaloupe and use some little cookie cutters and cut them out in different shapes. Make it interesting. Make it handheld. Those are things, kind of a walk away kind of foods that we think about, food trucks, wherever we're out and about. Those kinds of things are very appealing to toddlers. So discipline, okay, so we always think about what's happening in the toddler period. This is when we think about the tantrums, and the guy down here on the bottom right is certainly letting us know he's not happy. It's time for them to for you to set limits. They can only do certain things, and they learn to follow rules because you become consistent with them. It's important that the parent do that to limit negotiation, but finding ways to get cooperation. The techniques they use to assist the toddler to learn by problem solving. So sometimes you just do a 180 and say, I can't figure that out. How do you think we could do this? Offer choices, but choices that you're willing to accept, not just, broad random. It has to be within the parameters that you're willing to accept. So they're picking clothes out to wear. You pull 3 things out from the closet and separate them from everything else and say, pick one of these. They feel that they've made the choice, and they're wearing something you're willing to see them in out of the house. So how to, make it realistic by giving them a sense of autonomy is important. Keep the instructions simple. Reinforce desirable behaviors. What do we want? So you can forecast that. You're in the car and you're going to church. And so you say, remember, when we get to church, we're going to be quiet. We listen to what other people are saying. We can sing along, but this is our time to be quiet and listen and sit in our seat. And, then you'll get to go. And, if there's an incentive, is then you get to go to the playground after, or, whatever. So those are the kinds of ways as to how you give them the expectation of what you expect and how they can do it. So you talk about, we're going to sit, we're going to be quiet. You need to talk to me, you have to whisper, right? So learning things, extinction, how do we change negative behaviors? So sometimes we have to just put a halt to what they're doing because it's not safe, or it's so disruptive and it's time consuming. And so sometimes it's the timeout. When we use timeouts, for negative behaviors. It's very important that the child understands why they're in the timeout and that the amount of time you choose relates to their age. So we usually say for a 1-year-old, we do 1 minute, a 2-year-old, we do 2 minutes, 3-year-old, we do 3 minutes. So have a timer. The kitchen timer, almost everyone has a kitchen timer on the stove, is you set, when I set the timer, you need to do this, you need to be quiet, you need to stay here, you need to stand by the front door, you can't go anywhere else. Or, sit in this chair, whatever. And when I come back, when the timer goes off, you have to tell me why you were there. And then you're going to tell me what you're going to do instead the next time. So, and you can do that even with a 2-year-old. They do receptively understand your language. Keep it simple, keep it short, and make it consistent. So there's always a timeout place. And if you're visiting grandma, where do you do it? You need to find a timeout place that is a little bit out of the way, not disruptive to other people, but not where they're going to be distracted or where other people are going to come and take them away. So you want that limit setting happening. You want other adults in that environment to cooperate with your choice of how to discipline. So be clear to other adults in the environment. This is what we're doing. This is how I want it to go. So it's really important to use those techniques, be consistent wherever you can. And then we talk about toilet training, and that's a very big deal. So there are all kinds of books and stories and games and potty chairs and all kinds of things that are around to make that happen. Those of you who are parents can remember, it's like a huge, big effort. Everybody's sort of involved in it. And a week after it's done, it's like nobody even remembers. It's like gone. Okay. But moving up to it, making sure that readiness is a part of it. Don't do it until the child is physically able to hold stool and urine, get to, a potty chair or a toilet, and understand how to communicate to you that that's what they need to do. Remembering, of course, in the beginning that it will be last minute. It's always going to be, all of a sudden. The hardest thing I can always remember was standing in line at the grocery store and you're the next person up and I've got to go to the bathroom. And that's when you sort of wish for diapers again, because you're just like, oh my gosh, my life is disrupted. So, have the parent be ready to take it on, do it in a short period of time, and then it's done. So we always have some failure in the beginning. We don't make it a punishment. We set it up so that we have extra clothing, always keep extra clothing so that they can be changed. It's not a big deal. And you move on. Don't want it to be punitive if they've failed. So the most common way to think about, are they ready, is that they have regular bowel movements that you can somewhat expect. That they can express, and when the child is uncomfortable in a diaper and wants it off, that helps. The other thing is when they wake up and the diaper is dry, very important. It means that they've gotten through the night and their bladder has been able to hold the urine, and that now don't wait, because as soon as they're awake, they're likely to urinate into the diaper. But when the diaper is dry, when they're waking up, that shows you they have the physical ability to do so. They have to be able to follow some instructions. I mean, you can pattern their behavior, but you're not teaching them, you're teaching yourself. So teaching them early is not a benefit. It's more important that they are ready and they take it on, because it is part of self and how they identify with self. So we want them to have a consistent view of this is the way to do it and how to do it. They need to be able to move their clothes up and down. And so doing things with suspenders or, some of those overalls, this is not the time for that in the wardrobe. So move to things that are easy, shorts with stretch, that don't have lots of buttons or undoing kind of things, that the child can just push it down, pull it up. That's really what we want them to be able to do, as much as they can to manage their bathroom behavior. And you're always going to be a part of that in the very beginning, and you want to be able to monitor. Can they climb onto the toilet potty chair? Do you have a step stool in the bathroom, or do they have a little potty chair of their own that sits in the corner? You know, those things all work. Find out what works for you. Sometimes you've got one in every bathroom in the house and one at grandma's. So have the appropriate tools available. I think there was Sesame Street characters have some really cute potty story kind of things. I think it's Elmo, but you know, find the things that work. Talk to other parents what works for them, and know what works for your child. If they're resistant, if they're just not into it, wait. It's easier to wait and accomplish it appropriately than to set any kind of a negative trend about using the bathroom. And I think, you know, as adults, it's really hard for us, especially like when we have to take them to public restrooms, because the toilets are bigger, they have to hold on, and they're touching yuck, you know, and it freaks us out, you know, just from the hygiene point of view. So you have to take on this whole thing. So better to wait, because usually the longer you wait, the less time it takes. Again, we probably have lots of parents in the room that can share things that worked for them as well. So if you have the opportunity or need to know, reach out to your classmates who can tell you the very same things. So this is the end of chapter 26. And if you have any comments or questions, feel free to communicate with Erica or I by way of email. So thank you. Thank you for your patience. Remember, bottom line, parents are the first teachers. Help them model social behaviors and gender types, roles, those kinds of things are going to happen. Facilitate language development by talking and reading to their child, conveying cultural traditions and spiritual values, and providing emotional and psychological safety. So those are the roles of the parent as teacher, is engendering and making it personal to what are we about? What is our family about? So that they're able to not just feel like there's a rote script, but they interject what's important to them and their family. They are the first teachers. We want to always acknowledge that. And that's why our teaching and anticipatory guides are ways to foster that. Thank you for your cooperation.